Hello? Believe I've got it. Thank you. I apologize about that. We've literally had these about 3 weeks and just used them a couple of times. I'm calling to order this meeting of the representatives of the Knox County Mayor's Office, Knox County Health Department, and some of their representatives, and Knox County Commission. The purpose of this meeting is to discuss the Fitch and Associates evaluation of the emergency medical services system in Knox County and discussion of the resulting RFP for ambulance services. This is being recorded. However, we do not have anyone from the clerk's office. So just for the record, if each of you would please speak your name into the microphone, I'd appreciate it. Mr. Schoonmaker.
Mine's doing its update.
All right. Ms. Frazier.
Kim Frazier, at large, seat 11.
Larson J., at large, seat 10.
Carson Daly, seat 9, South Knoxville.
Richie Beeler, seat 8.
Rhonda Lee, District 7.
Terry Hill, District 6.
Gina Oster, District 3.
John Schoonmaker, District 5.
All right, and I did hear from District 2, Courtney Durrett, and District 4 that Kyle Ward, that they were not going to be able to make it this afternoon. Just to also for purposes of review, this is a meeting between the people recognized, so there will not be any opportunity for public discussion or for questions. So having said that, I'd like to introduce Kevin Parton. He's our Senior Director of the Health Department, and turn it over to you.
Push the battery in on the back. Push it all the way forward.
Kevin, while you're waiting to load, it would be extremely helpful to me if you and Fitch and Associates, as you're referring to the report, if occasionally you'd throw in a page number so that we could keep up more accurately with where you are in the report.
It seems to work.
There we go. All right, I think it's working now. Great. Kevin Parton, Knox County Health Department. This past January, this body approved a contract with Fitch and Associates to come to Knox County, meet with numerous stakeholders, and provide us an overview of our current EMS service, as well as give us some recommendations for the future of EMS in Knox County and the challenges that we have. Mr. Todd Sheridan from Fitch and Associates is here. He will give a high-level overview. He has a slideshow presentation to discuss his report, and then also answer any questions you might have regarding his report or the RFP as we go through that process. Director Myers is from procurement as well, and he would answer any questions about where we're at in the process and how that's working. So I don't want to speak out of turn with those regulations. Mr. Sheridan?
All right.
All right, Commissioners, thank you all so much. So my name's Todd Sheridan, Junior Partner with Fitch & Associates. I've had the pleasure to be here with you all for a few months now, and have really, I will say, for the team here that I've been working with, they have been open arms, open book with everybody involved. Now, about Fitch & Associates in our process. So when we started back about the February timeframe, we came in within our team, we came on site, and we asked for a lot of information, almost 200 points, data elements, and process for us to be provided by the county, by the EMS contractor. We asked for involvement from on-site and speaking with different stakeholders, from the EMS agencies to the fire departments to different ambulance companies, and include engagement with the hospital staff, because they became key to this report as we started to walk through. Now, really at a high level, as we started to work through our process, the first thing that we noticed, there was some critical key findings. Now, our key findings were derived from all these different stakeholder meetings we had on site, various different virtual meetings, and the information that was provided to us from either the 911 center or from your EMS contractor. Now, all critical findings that we come to within systems are not always bad. Okay, I want to start there. But as we start to walk through some of the challenges that we noticed here, as you all have been in a contract with your current provider, American Medical Response, since 2013, really under the same agreement. No new RFP process. You had 11 different amendments to that contract to kind of update as you went along. But as you were updating, then those updates became more frequent once COVID hit. And as you started to walk through the COVID timeframe, your EMS contractor also started to have challenges with the current model. What we noticed with your current model is that about 2020, between the market changes that happened, CPI, wages, the EMS contractor financially started to have challenges in this area. Now, we're seeing that across the industry. This is not new to just Knox. This is something we're seeing because in the EMS world, you kind of lived between, we'll call it the big box stores, the fast food restaurants from a salary structure, between a parity with the police department and fire department. You lived in between those moments. Well, all of a sudden, all those big box stores and all those fast food started raising their rates, and it became a challenge because EMS had to start raising rates as well. Cost of doing business increased, and even prior to COVID, we had seen a recent study that we did with Fitch & Associates that noticed CPI had outpaced over the last 10 years by about 7% from actual cost versus revenues provided within the EMS realm. So one of your challenges in the first critical finding we had is just your market changed. And so the contract that you currently were under was not going to be financially feasible going into an RFP process to obtain a bunch of bidders. So we wanted to make sure that there was a fair process, that there was a process and a procurement process that would make win-wins for both you all getting what you need to make sure you are able to service the community, as well as have a win-win for a provider that's able to work here financially. Critical finding number 2, response times do not allow for equitable community response. Now, you start thinking with it from an equity standpoint. The way the design of the contract that you were under was the entire county receives one response time. As we go through this presentation today, what you will notice, a lot of your response happens in a finite area. So what happens is your current contractor, by contract design, only has to staff a certain portion of your county, which leaves the rural communities with elongated response times because they don't have to cover that to a different measure. So that inequity needed to be corrected as we started to move forward. And we'll walk through that here in a little bit to talk about what the times we found. Now, one of the biggest pieces that we found is that the current hospital times, or what we allude to as wall times, are excessive and will prevent any provider from being successful. And what I mean by that is currently your current EMS contractor sits about 6.6, 6.7 units or 12-hour units a day. So think 3 24-hour units worth of EMS providers just standing against the wall waiting to hand over their patient once they get to the hospital. They're there on about an excess of what we consider about 40 minutes on average than what a normal standard should be. And in your top 4 hospitals that are within your community, which we'll talk about, covers about 86% of your volume where they transport to, are up in the higher 50 range minutes on average, and up into the 90 minutes at the 90th percentile. That's costing the EMS provider just over $4 million a year worth of providers standing against the wall and not being able to respond within your community. Now, One of your other challenge points is with your current EMS contractor to date and the way the contract is designed, they provide you month-end reports. They provide you the data. They provide you their information. The challenge point is if that contractor was to leave you and you were to bring another contractor in, then you're starting from scratch. Now, you do have your county dispatch, which does have a robust program. So you will have their data, but then you still have to make connectivity. You still have to get your reports in place. That transparency and that oversight from irrespective of who you have as a provider right now would leave if your current contractor left and you had to put somebody else in. So we're saying from a medical direction oversight and from a software oversight and dashboards, processes, that you all own that software. You all have a singular medical director to provide a systematic or a system of controls for your community. And last but not least, and we'll talk about this more, is your mission area requires significant resourcing of the EMS system. You'll see here in a minute as we start walking through some of the mapping and talk about where the hot spots are within your communities, a lot of resources from EMS are being tied up in the mission area. It's kind of what you have, a lot of volume, a lot of transient volume. But that transient volume has also contributed to some of the other healthcare needs within your community, also affecting payer mixes as it relates to your EMS provider. And we're going to walk through that here as we walk through the next few slides for current situation and critical findings. Overall, within your community, though, what we looked at was about 5 years worth of data from 2018 to 2022. We were able to get a pretty good picture of what happened both pre-COVID and what's going on to date and try to do some normalizing as we walk through what happened as you went through COVID. What I will say, though, for the community is your overall number of transports and your overall calls have been fairly flat. They haven't gone up, 2, 3, 4, 5% each year. They've actually been pretty flat on the growth scale when we say volumes. What we will say, however, though, is that you have a lot of what we consider deemed critical calls, meaning dispatched as paramedic and being transported as BLS or low acuity. And we'll talk more about that as we walk through system design. Now, as I had mentioned before, that equity of response. Now, I'm going to just stop for a minute and talk a little bit about and I'll touch more about this later, but the original contract design was for your EMS contracted agency to respond 10 minutes, 90% of the time within the county, okay? During COVID, because of some of the challenges and some of the revenue, wall times, whatever, that time had been increased to 17 minutes at the 90th percentile. Now, you think, okay, that's a 7-minute increase in response time. That gave a lot of value back to the EMS provider to be able to have that elongated response time because decreased performance adds cost. So if you want to go from 17 to 10, there's more cost associated to staff for readiness. If you want to go to 10 to 17, it's less readiness you have to staff for and you're covering more demand. We'll show that in a chart in a moment. But what this chart will show is in the Knoxville area, and before I go there, let me say this. You'll see as we go through the slide deck, there are about 6 different zones, and we'll call them city zones. These were derived from your EMS contractors' data, and so they bucket into 6 specific areas. So they may not specifically correlate, but they are geofenced around into specific areas within your community. Now what we'll talk about is Knoxville. So in Knoxville, you will see in 2022 when they had a 17-minute response time at the 90th, they were able to meet that time at a 16.9% is what your community experience was. So from a raw performance, meaning not taking exemptions into a place or any other reasons, your community in that area received 16.9, so about 16 minutes and 50 seconds of a response in Knoxville. Now what we learned is that's about 90% of the overall volume that happens in that one area. The challenge point is once you start looking at Farragut, Powell, Corryton, you start to look and you say, okay, well, were we getting that same 17 minutes in those areas? Well, no, because the resources to cover to a contracts perspective, so from a contractual perspective, to meet that was really the core of the business where the highest volume is. In the fringe areas, in those rural communities, they would have elongated times. In certain areas of greater than 20 minutes in pretty much every community except for Powell. You even had upwards in Corrigan of greater than 25 minutes. In Strawberry Plains area, greater than 26 minutes at the 90th percentile. So as we start to understand from a system design, this is where we have to understand how to make sure the center core, the high volume, the high density, the high risk areas are managed appropriately. We got to make sure the rural communities from a system design are taken care of as well. As we start talking about system design moving forward, we look at it from managing risk. And of course, we understand risk is a big part. Risk and cost all kind of go hand in hand in what we can put into systems and design. First thing we have to understand is just simple heat map. So when we looked at your system to understand where the volume, the concentration of volume is, you will see right in the center of the city in that mission area, you'll see is your highest density call activity, which if I'm looking correctly is about 3,500 calls a year in just that area alone. Now on the right-hand side is what we call an urban-rural risk matrix. So what we do as Fitch & Associates is we look at your area and we look as a commensurate risk mapping. So instead of where a hotspot mapping concentrates to just a density area, we look at it from a risk profile. And what we say is if there's a singular call that happens within a 1 kilometer by 1 kilometer square, if you have 4 calls that happen per month and 50% of the adjacent sides, we consider that a high risk area. So it is deemed red on your map. If you have green area, which we consider a lower density area, or rural, that's where we have 2 calls that happen every quarter with 50% of its adjacent sides. And if you don't see anything, that's what we consider more of a wilderness or very low risk because there's low call activity that happens in those areas. So what this does is help you normalize risk. It also helps you design response to those areas to manage risk collectively when you start talking about creating equitable zones. So as we start talking about response time review, I had mentioned right off the bat that the original contract design was for 10 minutes at the 90th percentile. And it was increased to 17 minutes at the 90th percentile because of the challenges that were going on in the market space. What we've indicated is that at that same time, in speaking with your current EMS contractor, financially they were losing about $3.4 million a year at that time. Now they've been losing money on this contract since about 2020. And so financially they've continued in this contract even though they've had those financial losses. The response time change that supported the system, we believe, helped gain about $4 million back into the system of not having to buy readiness, as I mentioned earlier. Now, that did come at a cost and an increase in response time. However, it made the loss much more manageable. Now, we also noticed in the rural communities, or let me back this up. We found out that there was a 7-minute response time forgiveness being also applied if a paramedic was on a fire unit and the ambulance was coming. So basically you would get an additional 7 minutes for a response time. What was happening was across the community that was not being applied evenly because you would have maybe some of the county fire departments that would have a paramedic and they would mark up with dispatch every day that they would have a paramedic. Or maybe the city fire department would have a paramedic, but they did not mark up with the fire department. So it was not being applied equally across your community. Now, as we start looking at that, because of that it not being applied equally, that creates a challenge, especially from a system design. So as we start talking about system design moving forward, we talk about creating those equitable response zones. We also talk about removing that 7-minute forgiveness. Compliance is compliance. Whatever you decide as a policy group moving forward, as we will talk about with some of the options we provided, as a policy group moving that forward, the compliance should be compliance. It shouldn't have some type of forgiveness, especially when it's not applied equally. And last but not least, the system currently it needs to be financially responsible, meaning that it needs to be a win-win for both parties to make sure something's sustainable for your community going in through the next contract cycle. Now, we worked with AMR to understand a little bit about their operation. And when we did, and I'm going to explain this map so it all comes clear here in a second. But what we had to understand was how they were deploying resources into your community. And what we also wanted to understand was how, if they were deploying it for, let's call it a 10-minute response time, how that was occurring and what some of the impacts were. And then what some of those changes were when they went to 17 minutes.
Page 21, if you all are.
Sorry, I'm using the computer, so I apologize. I can't look right at the report. Appreciate that. As we start walking through this, though, the first thing that we have to understand is that when we design systems, you design demand and performance based on 3 factors. How many resources that you need just to cover geography as it relates to your contract design. So when you're covering the historical performance, you need to understand how many resources you have to have deployed. Then we look at how many calls you need by hour of day of week. And we take that over 52 weeks and we give it an average. Then we look at how long those calls last. Not every call is 60 minutes, so we can't just do 1 call an hour. In your case, it's almost an hour and 20 minutes. So you have to apply basically an hour and 20 minutes to every call to make sure that you get the right distribution. On the map on the left-hand side is what was a drive time map. This is what AMR gave us that was their current deployment, or excuse me, their deployment and vehicle move-ups. So as you may know, they do street corner posting. They move from one place to the other based on where the next potential call is going to be. And they have some designated posts. Now from those posts, we then took and applied that and said, okay, well, how much volume does each post capture? And we use what's called a diminishing return model. So what's the value add of each one of those resources to cover historical volume? So in this case, for their post number 1, when we looked at our map, we put all the calls on the map. We had our system designed and say, okay, at a 10-minute drive time, which one of these posts would capture the most volume? So in this case, at Paper Mill and North Shore, at 10 minutes would capture about 40,000 of your total calls. Now, one truck's not going to run that, but that's what from that post could capture, which is 62% of your overall historical volume. Then if you look at your AMR's second post, so you remove all those data elements, rerun the system again at Maynardsville Road and Brown Gap, you add about 7,100 more calls are captured, and you add a value of about 11% more capture of historical volume. As you start having a diminishing return moment, you get that they need 6 units within the system, which are the green drive times on the map, to cover 92% of your historical volume. So they'll need at least 6 trucks covering geography just to cover the contract at 10 minutes. And let's keep a hold of that number 6 because it's going to be important here in a second. Now what you'll see the 2 charts that you'll see at the top. The first chart at the top that's all green is, and I'm going to explain to you, is our what we call staffing to demand analysis. We're going to work from the bottom up. So the green bars that you see are the demand by hour, by day a week, Sunday to Saturday. And that's a normalized demand for time on task for each one of those calls. And then we applied those 6 geographic units in the area chart in blue. The blue line is what we call our geo demand. That is where you need to have that minimum covered if you're going to meet contract compliance. The top chart is the red line is the current attempted to staff by your current EMS contractor. That is what they're trying to staff every day. However, in speaking with your EMS contractor, they said they were about 65% staffed at the time of our study. So we indiscriminately just took 35% right off the top for every hour of their staffing. And as you will see, the bar charts turn yellow, meaning they're unable to meet the contract performance based on the staffing challenges to meet that. So that's where now we start to understand what happened at the staffing side and some of the other market challenges that happen within the community. Now let's advance forward just for a minute to deployment for 17 minutes. Same scenario, we did that same marginal utility approach, but in this case, instead of needing 6 units, you only need 2 units to cover 17 minutes. So you have a value add back in the system, or you don't have to buy readiness of about 4 units. So that value add now is either back into the staffing model, or you don't have to try to overstaff anymore. If you look at that second chart again, the top chart is what they would be trying to do, but the second chart is only 2 geographic units instead of 6 in the area chart. And as you can see, the contractor should be able at 17 minutes to perform, which is what we noted early on into the equitable chart that we started on our third slide. So as you can see, the contractor is able to perform at that 17 minutes. Now, as we start talking about the wall times and some of the challenges that have happened within the community, I had made mention that 86% of all the calls cumulatively go to 4 different hospitals within Knoxville, or Knox County, excuse me. Within these, you will see on the left-hand side, on average, University of Tennessee Medical Center has 55 minutes and greater than 55 minutes hospital turnaround time, and at the 90th percentile is 88 minutes or greater than 88 minutes. When we start talking about industry standards, we start looking at 20 minutes at the 90th percentile, about 13 minutes on average. So when you start looking at the wasted number of unit hours, we start trying to understand how that applies. So if you look at on average, 53 minutes is what we looked at across your hospitals, having an average wall time of 53 minutes. If you're going to be an average at 13 minutes is what the norm would be, then you would have a wasted amount of about 40 minutes per transport against the wall at the hospital, meaning that 67% of their time per hour they're on the wall at the hospital. Meaning if there's greater than 43,000 transports, there's almost 30,000 wasted unit hours. And if you look at 12-hour shifts, which count to 4,380, or your total number of unit hours per 12-hour shift a year, that means 6.68 wasted 12-hour units for standing it against the wall. And the estimated unit hour cost for this system we did as Fitch & Associates was just over $100 or $140 per hour per truck that is in the system. Meaning that just wasted standing against the wall was just over $4.1 million of just resources standing there turning over patients to the hospital, and they were not able to respond within your community. So one of the last critical findings we also had was some of the impact to, as we talked about, some of the mission district. What we also learned was when we start talking about the finances and some of the challenges in the community, also involves your payer mix. Payer mix is key, right? If you have current Medicare, or Medicaid third-party insurance, your governmental payers, they're capped. But the challenge point is where you normally get your funds and have more of, I'll call it your better payers are in your or in your commercial insurance. Where you get your most challenged payers is actually at your private pay. And then you do get some of your Medicare HMO, but however, they are a less payer than Medicare and Medicaid. If you look within your community and what we have seen, and we'll start at the bottom, your Medicare has reduced over the last 3 years by 6%, which is typically your guaranteed payer, and it's a consistent governmental payer. And it goes up year over year based on CPI and what the government applies. there's been some increases also for sequestration, or some increases from Medicare and a little bit of sequestration that's happened. However, the payment for Medicare has been going up to try to compensate for some of the market challenges. However, you had a large shift. 6% of your payer mix has shifted away from Medicare, and you've had a 3% increase in Medicare HMOs. But your largest change, which is typically only about a 1% of anything you charge payer, 1 to 2%, is your private pay. And that's gone up also 3%. So your challenge point is your payer mix changed during that same time frame, giving you a challenge as it relates to the amount collected because of your population of folks being transported. Now, those are some of the high-level parts, and we'll talk a little bit more at the end of other considerations. I want to just touch on, since this is more of a high-level presentation today, I didn't want to get down too much in the weeds, but we'll touch more on that at the end on some other considerations. But those touch really the critical findings. Now, as we start talking about the pathway forward, I'm just going to give a little bit of background. So, as Fitch & Associates, we came in and we worked with the team from here in Knox County, and as mentioned, we went around and we spoke to all the different stakeholders here. After we had our preliminary recommendation and our draft findings, we then came back and we represented to that same group of folks. So the same fire department folks, dispatch, the county, stakeholders at the hospital, we came back and we presented really this same information to those stakeholders. Received secondary feedback to make sure that we were working back and forth. Collectively, though, with Fitch & Associates, we put in and we presented about 35 different options, both operational options and financial options to the county. The reason why we did that is because ultimately this becomes a policy decision. Fitch & Associates is not here to give you a one-way path. As a policymaker, as a group with the county, our goal was to give you options. So as we started to walk through those options, what we looked at was various different models to include still using your performance-based model today, purchasing unit hours, which is considered what's called an alliance model. And we also evaluated what the cost would be for the fire department model to do that if they work the same street corner posting and the same workings as your system does today. We applied cost to each one of those models to understand what response time changes if you want to go from 10, stay to 17, if you want to have a hybrid 10-20, 10-15. We walked through all of those moments together with your staff. Our goal with that was to then say, we have provided you options, how would you want to move forward? We're going to talk about the model today that they have chosen to move forward within the RFP. But there was a multitude of different options that were provided that they could pick from. Bless you. As we start talking about options moving forward. Now, following our review and putting together the options, there was some discussion further on other means and looking at the RFP, especially around dispatch and process. Those dispatch and processes could either maintain costs within our model or they could increase costs just depending on what's chosen. However, again, those lead into local policy decisions. Now, like I had mentioned before, some of the limitations that you are still going to experience. And what I mean by that is irrespective of us presenting a model to you today, right now you're challenged as it relates to staffing. A lot of the world still is, right? So if you're still 65% staffing and you adjust the model, there's probably going to be a lead time and still some challenges that relates to getting into the next model irrespective of the provider. There's still cost to complete the service. So as we start walking through, maybe a bidder will come in and say, you know what, I want to give everybody a certain raise. And they add that into their costs that we aren't familiar with as a firm. The last piece is also your community makeup. We're noticing that we're seeing a lot of areas doing revitalization projects, or we're starting to see a lot of urban sprawl within communities. So where communities are really honed in on, let's say, the core of the city, starting to have that urban sprawl where you're starting to see more folks gravitate out into some of your communities, which my understanding in flying here today, there's a lot of construction going on in your Northwest region. So we can't predict those in the modeling. However, you have to be cognizant when you're designing an RFP, how you can have it still flexible to pilot new programs to take care of that into the future. Now, being within your community, just to make sure that we looked at various models, not just said we picked a number and went out of thin air to say it should be 10 minutes, or should be 12 minutes, or 17 minutes is right. What we need to do is ground that in some accrediting model. We use the commission, in this case, use the Commission of Fire Accreditation International model that looks at 3 specific parts of your response. It looks at your alarm handling time, so in dispatch, which would not be your EMS contractor's responsibility, but your turnout time, how long it takes them to muster and get wheels rolling, and also travel time. Now, travel time, the Commission of Fire Accreditation International looks at population against square miles based on the area of response. So trying to normalize the response to make sure you're managing relative risk. The first unit in these responses are really based around the medical first response. The second unit is based around your transporting EMS resource. So we started to design moving forward, we started to look at, okay, what is that relative risk and what would that response time look like? So this chart helped us as we started to look at those designated geographic areas to understand what is the response and all the volume happening in these specific communities. What's the specific square miles it covers? Population in those areas. What is the population against square miles, which helps us understand if it's considered a suburban or rural area. And then what the Commission of Fire Accreditation does really well is they give you kind of a goalpost. It's called benchmarks. They call it the benchmark and baseline, okay? If you can get to the benchmark, great. If you can staff to it, you can deploy it, you can fund it, great. But there is a baseline that you should be at. We looked at that for both the turnout time and mustering, which is 60 seconds to 90 seconds at the 90th percent, and then the benchmark time for travel time. Now you can see in each one of those at the end, if you looked at your just Knoxville specifically, you'd want to be between 9 minutes and 11 minutes and 54 seconds. That to be said, currently right now that area is at 17 minutes. If you were looking at all the other areas that were associated with within our review, you'll see that they're almost at 20 minutes at baseline, and currently right now you're north of those 20 minutes. So as we started trying to understand how could you make an equitable response moving forward, what we looked at was in your communities, and we worked with your team here locally to determine what would be the right areas to divide for, call it a suburban or urban response versus your rural responses. What we also determined was that in your core area in the red, what we're going to call the incorporated area, that area is high and densely populated and should be considered in that 10-minute response time. However, when we started looking at the county, if you just wanted to look at it without dividing it east versus west as a response, you could really shift all your resources just into the western side and not cover the eastern side. So to make sure that both you had equitable response east versus west, we looked at the historical volume and worked with your local leaders to help create the east versus west rural communities to make sure now it forces resources, forces the contractor to cover your rural communities and not just hone in solely into the incorporated areas. Because right now, contract design allows them to do that. It doesn't force them into your rural communities. Sorry, I'm gonna back up one. I wanna touch one more piece to this. What we also then looked at was your response times, not only just for your life-threatening, but we also looked at your urgent and your low acuity calls as well to understand what a response time would be for both those incorporated and east versus west rural communities. And what we wanted to do is we wanted to make sure that there was a prioritization that was put in place so that, let's say you're going to a lower acuity call and a higher acuity call comes in, there's a mechanism for you to divert, let's say, from an abdominal pain to a cardiac arrest. We wanted to make sure that from a triaging perspective, because in your dispatch center, you do use a triaging tool that does help you identify your critical patients. Now, as we had mentioned earlier, we worked with about 35 different and reviewed about 35 different models. In our review of those 35 different models, really bantered around between the county folks we were working with. They looked at a blended model to cover the city and also the rural communities. We looked at both a 10-minute and 20-minute, a 10-minute urban response, 20-minute rural response. And we also looked at a 10-minute urban response and a 15-minute rural response. Now, again, it's a local policy decision, but these were the two models that were ultimately looked at the hardest. We wanted to show them today. Now, as I had mentioned before, how many vehicles do you need to cover the geographic area? So what we did was we looked at first, how many units do you need to cover the urban area? Then how many do you need to cover the rural areas separately? What we found is you would need 4 geographic units properly distributed to cover 10 minutes and 10-minute urban, 20 minutes rural at the 90th percent. If you want to go to 10 minutes 15, it would take 5 units to do that. So locally, from a policy decision, it was chosen from the RFP process to go through the 10-minute, to do the 10, 20-minute model. Now that was just to cover the high acuity calls, those priority 1 responses. What we also understood is the current EMS contractor by design, except for here recently through COVID, was trying to staff every resource as a paramedic, with a paramedic on it. Being dispatched, they were dispatched about 92% of the time with needing a paramedic. The challenge point is they were transporting 30% of the time with basic life support being provided to the patient. Meaning 30% of your patients had a paramedic EMT at a minimum responding when they could have used an EMT resource, the most costly resource that you would have as a paramedic EMT. However, they were also trying to respond in such a way that maybe was still using lights and sirens. So what we wanted to do was add what was considered a tiered system. So for your low acuity, adding into the contract the ability to use BLS units to cover these calls, which we believe takes 4 trucks 24/7 to capture those resources or that volume appropriately. That does not diminish taking away from your paramedics needing to be on your priority 1 calls. Last but not least, the state of Tennessee has worked to also adopt AEMTs, advanced EMTs, as being able to do life-threatening call or doing the ALS calls. Challenge point is that's not the same level as paramedics. So our recommendation at this point is that the AMTs, if they wanted to use a priority 2 response or be a part of the low acuity priority 3, absolutely, but paramedic at a minimum for your life-threatening calls. So going back to understanding what a staffing demand would look like for an EMS contractor, irrespective of who it is would need to staff this model, they'd be looking to do 4 units BLS 24/7. And if I'm looking at it correctly, it's about 17 units at peak of day for ALS during your highest volume periods to be able to cover appropriately for your community. Now, your current EMS contractor right now by system design does not have to do that because they're only trying to meet a 17-minute response time. So there would be an enhancement to the system on expected resourcing for this model. Now, as we start talking about the system performance moving forward, whichever model you're choosing, what we don't want to do is decrease customer experience or customer expectation. So that's why as we started to walk through this, we looked at each one of those cities to make sure the rural communities were being taken care of and also the city was not taking a step backwards either. We do believe that a tiered response, ALS and BLS, should be considered in your next RFP. Allow BLS units to run those priority 3 calls, keeping the paramedics ready for those life acuity or those high acuity calls. Again, eliminate that 7-minute extension with a paramedic on a fire truck. Provide that equitable coverage for your community, and then eliminate level 0 fines. One of the parts that you have contracted for is a performance-based contract, not a staffing model contract, meaning you're not expecting them to have a certain staffing and then say, okay, well, because you didn't have that staffing, fining them because. The challenge point is performance-based. You may be in a hospital and come out at a level 0 and you still make the call. So the challenge point is you either penalize them on performance or you're penalizing them on staffing. We believe if you're staying within a performance-based contract, you penalize them on performance and not just staffing. Now, depending on the model chosen, and as we had mentioned, the county had chosen to move forward from a policy side as the 1020 model. We believe that there's a range of costs that were associated that would come back to the community here. You've been fortunate enough to not have a cost imposed because of the community makeup, because of the market space that you were in, but unfortunately about 2020 that shifted. And we believe going into this contract, you could expect to spend about $1.9 to $3 million to create that win-win situation for any provider to come in a performance-based model to operate within your community. Now again, different performance standards adds different cost. If you wanted to go to the 1015, there would be more cost because you would have to add another resource to cover that geographically. Depending on how much you allow your provider to charge from a charge master, they may be able to collect a little more from third-party insurance. So depending on how they bidded, you might see more, they might get a little more revenue. Depending on the dispatch model you chose, that could add cost. Last but not least, depending on the options your provider that we don't know about could add cost to your system. But our range is based on your current charge master, and again, adjusting a charge master to 300% Medicare allowable. And then we believe your cost would fall between $1.9 and $3 million. So coming to conclusion here, we took all your other contract considerations that we saw, and again, we didn't go into high depth in your current contract, but we wanted to touch on just a few pieces that we felt would be important to touch on today. There's more of these within the study and the document associated. However, in working with the Knox County folks, your stakeholders, listening to your community response, your response folks, fire departments, hospitals, what we derived from that conversation is a bunch of different contract considerations. First is we believe the county should hire its own medical director, have its own clinical oversight to ensure everyone's being treated equally, all the way from dispatch to medical first response to the EMS agency or EMS contractor. That way that medical director is ensuring that the clinical care across your entire community is being handled equally. You're looking at handling it from an EMS system and not just based around one provider within the system. The county should own and operate all of its operational and clinical performance metrics. Part of the contract that we looked at was putting clinical performance standards based on what we call process outcomes. And those process outcomes are based around what we call code stroke, code heart, code trauma, code sepsis. We look at this agency's specific protocols. That software, both operationally and clinically, should be owned by the county. So irrespective your contractor is successful or maybe they're not, you own it so you can change out providers, or if you decide to take it in-house, you already own the oversight software for them. Last but not least, when we used to do RFPs, we talked about RFPs needing to start with brand new vehicles. It limited your maintenance cost. Unfortunately, if anybody's gone to buy a vehicle these days, that's not something you can do. And EMS is about 24 months of getting new vehicles if you try to order today. So what we're saying is that in your contract, to try to control some of your costs and some of the maintenance costs, no vehicle should be over 7 years or over 300,000 miles. Vendors should be required to have a mutual aid plan with all your surrounding jurisdictions. That way, if you have a surge in response, you have a dedicated backup, and if you're county, you have a reciprocation to your neighboring agencies. Decedent transports. We heard loud and clear that was a challenge. So what we did as part of this contract, we worked with the county, we listened to the folks, and we believe that there should be a response time associated with your decedent transports. That was not that way previously. So having a dedicated response time for decedent transports, but allowing one person being dedicated to, if they so chose, to be able to do those decedent transports. On one of the previous slides that I talked about the hospitals, if you don't know, decedent transports take up about 7 hours on average per day within your community. of just moving to seat and transports. So it's really, there's a lot of resourcing being done with that. We talked about mobile integrated health and community benefit. The government has not started to fund programs such as people going checking on folks at home or trying to help reduce the frequent users within your system. If that's something you so choose, which is a community benefit, and you as a policy group choose that as a good pathway forward, or to continue with different dispatch protocols to navigate people through the system differently, those are added cost. However, those are policy choices if you think that's best for your community. Ensure that whoever the EMS agency comes in directly connects or works on the dispatch CAD that you have. You have a very robust dispatch center. You have the opportunity to keep an agency within the roof there. Believe that should be continued. And irrespective if they don't stay within the roof or they decide to use their own CAD software, there needs to be a direct CAD to CAD interface that ensures you collect all the data in real time so you're not just reliant on somebody providing you data at the end of the month. Hospital wall times are going to have to be addressed. That is not only a financial impact, but operational impact to whoever your future EMS contractor is going to be. That challenge point, holding six 12-hour trucks or 3 24-hour trucks against the wall, is undoubtedly, with somebody standing there with healthcare officials around, unable to be able to drop those patients off to go into your community and get somebody that doesn't have a healthcare provider next to them or to meet a performance standards is going to be a challenge. Fixing that is going to be a huge benefit for you in resourcing within your system. Last but not least, the mission area that you have within your community, being the transient population that you have, that's going to take a multifaceted healthcare approach to address. That's not just an EMS agency that's going to be able to do that solely. That's going to be partnerships with the health department, with the hospitals to be able to address ways, because right now you're reliant on somebody calls 911, they go out, and then of course EMS doesn't have a means to turn people away. We have to transport if somebody says so. So that's by the way the system is designed. So as you start moving forward, looking at those community benefit programs, partnering with hospitals, helping with ways within the health department to work on the mission area, those are going to be key to the system's success as you move forward. And with that, do you have anything else? Okay. Be glad to take any questions.
Are there any questions? I'm sure there are. Commissioner Schoonmaker?
Thank you, Madam Chair. In your presentation, did you mention that in Knox County we have 4 hospitals?
No, I said the top 4 hospitals that are 86% of the overall time at the or is accumulating 86% of the overall time at the hospital.
Okay, so the 5th hospital, who is not requiring a lot of time?
They all are requiring a lot of time. They are, sir.
Okay.
Yep. So if you look at it just in general, and I'll look at just the top ones that we have on the slide here, I'll go back to it. You have University of Tennessee at on average 55. Then you have your Regional Medical Center 54, Park West 54, North Knox 57, Turkey Creek 45.
Okay.
Your forensic lab is the lowest at 28. We did do that as turnaround. And you can see the rest, they start hitting that diminishing return moment, but they're still going into the 50s.
Okay. Okay. Thank you.
Yes, sir.
Commissioner Daly?
Thank you, Madam Chair. Thank you, sir, for being here.
Thank you.
Got a follow-up question on the hospitals. Seems like the hospital, they're understaffed. Nobody wants to work anymore, and so they're understaffed. That's where the problem starts. Because instead of waiting 40 minutes or 50 minutes or an hour, if it was staffed, they could get back on at 13 minutes, and we wouldn't see a lot of these problems. And it's not the hospital's fault. We just, they're trying their best to do what they can do, but it starts there. Did you check into the drop-offs from other county ambulance services? I know at UT, you go down Alcoa Highway, Union County, Anderson County, Sevier County, coming down Chapman Highway. That's taking up time. Did you check into that?
So make sure I understood your question. That we checked into other counties and other hospitals and what their times were?
Well,
I just want to make sure I understood, sir.
us being a metropolitan area with the trauma hospitals that we got, surrounding counties are going to send them to UT, or they're going to send them to, I think, Tanoga, one of those out there, or high trauma centers. They're sending there, and that's taking away beds or taking away time. Did you consider that?
So we did not consider that because that was not part of within the scope for us to look at the hospital times. Now, I will say there was good engagement with the hospitals during our study, and they understood some of the challenges, both from what they're seeing in the hospital, also at some of the turnaround times. Now, addressing those nationwide has been a challenge, even above our own borders in Canada. We've been fortunate enough to work up there, and you can see some of the challenges. This is not unique to Knoxville right now, but unfortunately, people are handling it differently. And so as you start getting engagement with the hospitals, as this starts coming to the forefront, as we start working through some of the as we're starting to see that some of the quiet hiring, as we heard in Becker's report the other day, you're starting to see some of that turn within the hospitals, but it's a slow moving process. And the reason for us pointing that out is, again, irrespective of who your next EMS contractor is, going into the RFP, just being cognizant that that's not going to change overnight, that you're going to continue having these system problems, irrespective of the provider, is just what we want to set as the understanding. So the better you're able to help with the hospitals, the partnership you have with the health department and the hospitals, that's going to start freeing up for the EMS agencies.
Yeah, I agree with that. And that's a lot of the questions I get. Been getting requests, why don't we have a county ran service? And I tell them, if it was county or if it was private, we'd still have the same issue. Because it's the labor issue is basically what it is. So, do you know you just did Blount County?
Yes, sir.
And how's that working out? Does that compare kind of what we're needing and what, I know they're a smaller county, but they're.
So I'm actually in the process of doing their annual report right now. So that will be coming out here in the next couple of weeks. What I will tell you is in their report, and again, they just got their draft the other day, but that's moving along pretty well. And so they've still got some pieces that they need to check off. Their piece that's much, much different, your geographic makeup, your density of populations, the number of hospitals that you transport to is a much different makeup. Your community makeup and your challenges, especially with the mission area, that's creating and affording you a much different situation than they are out there. Now, the situation's working for them, and and I'm not going to go too much into that report because it's not public yet, but it is working for them, and they still have some growing pains, but all in all, that's working for them. But you are a different makeup as it relates to a community, your challenges and needs compared to Blount County. I
agree with that. Like I say, we're the metropolitan county that they're going to send to. Very interesting about the software and the EMS contractor. Is there any surrounding close areas that already do this I can understand the software for sure. We need to be safe to where we own that software, and if something happens, we still control it. The EMS contractor, kind of interesting there. I'd like to know more about that. What would be the advantage of that?
Yeah, so a couple advantages. So think of it in this direction. Let's say you have contractor A that you have today, or contractor B you might have tomorrow. Let's say contractor A is unable to perform. They leave, you can bring contractor B in, and the expectation for the system's the same. The way you manage them's the same. All the processes and reporting's the same. So you don't have to go, well, I need to make this new report up. I need you to produce this. What ends up happening is you have all the controls. You have the expectation for your community and how they're cared for, set up by the medical director who sets all the protocols. So as a system, irrespective of who the provider is, it allows you to have that consistency. So you either, maybe one provider doesn't work and you want to change to another provider, or you want to turn it and make it a county run system. However you work that, the system of controls are in place so that you're not losing that control every time you change a provider. Thank you.
Commissioner Jay?
Thank you, Madam Chair. When you worked with the hospital, did they offer any commentary, any solutions, or did they just said, tough, that's the way it's going to be,
I think it was an education back and forth. I'm not going to say right now that there was any offered solution with the conversation. Our lens was looking at where the challenges were and identifying those and bringing them to the forefront. We didn't walk through them, nor was our scope to help them with that side of it. However, what I will say is no one ran from the conversation. Everyone was highly engaged. Now, how
but if nothing changes,
but
you can have all the staffing in the world.
Correct.
But if you don't have the support from the hospitals to figure out a different method, and maybe it may be just staffing on their side too, but it could be a different way of processing. It could be a different way of triaging. It could be a different way. There's 100 different ways to try to find a solution on the staffing side with AMR, our current provider was there any discussion from them about how to get better staffing? Even if it's a challenge nationwide, you still have to manage your business.
You do. So I'll talk a little bit about that. So what I will tell you is when you're looking at the market space and where it's at today, financially, what has adjusted, I think we're doing a lot of learning as an EMS industry. You're starting to see places in Texas. We're running a program down in Lubbock, Texas, because we actually, not only with Fitch & Associates, do consulting, but we actually do and manage different programs across the country. And for the first time ever, we're starting to see salaries that are just outpacing just different providers or fire departments. Are starting to see parity where we had not seen that before. So that financial impact on an old contract is going to be a challenge for any provider, irrespective if it's American Medical response to the next one that was in this contract you have today. What is also going to be a challenge part is the longer this drags out. I will tell you, after running systems and being a part of private systems in my early years, contracting timeframes become challenges just from staffing because it's the unknown unknown. And so as you start walking into contract cycles, you do have that challenge. Now, if it's something locally, we didn't go in and review AMR specific, any of the management on site. We didn't review AMR, so I couldn't tell you what their specific challenges is for staffing. I can just tell you that in the market space, it's challenged. We're starting to do in some of our programs with our management services, we're having to do what we call just teaching EMT classes, bringing people with no experience just to bolster staffing, paying to go into paramedics or paying people to change industries. We used to not have to pay for that as an industry. We used to have people come in, they would volunteer at nights, they would get their EMTs, they would pay for their own paramedic, and then they would come be a provider and happily love it. And then they would stay, or maybe they transition to somewhere else in the healthcare system or public safety system. The reality is now, though, we're having to attract people, we're having to train them, we're having to onboard them at the same time as the markets are shifting under our feet.
Mr. Parton, I might be getting ahead of ourselves in the process, so tell me if I am. When we, based upon the report that we've been given, will we have the option to say we want our own dispatch to handle things with our own software and let's piece that out? We want decedent transport to be in a different bucket. We want, or is it just going to come as a lump sum recommendation that, it's yay or nay?
So the RFP has already been released and we're going through the evaluation process. As Director Myers will tell you, all points inside the RFP are negotiable. He's said that many a times. Inside the RFP, decedents transports is separate in terms of response time. We do have clinical control with the medical director. We will also have the utilities that Mr. Sheridan was talking about from a software standpoint. There was the option for them to bid and provide cost for two models. One was they will dispatch and triage their calls themselves. The others was Director Anders' team would take that call triage it, and then send it for dispatch. So there is two separate models depending upon what that looks like.
So when all those things come to us as a legislative body, though, is it coming with recommendations of this, that, and the other, or is it just?
It will come as a single contract.
Okay, thank you.
Yes.
Commissioner Oster?
Thank you, Madam Chair. Thank you for the information. It's been extremely helpful. Unfortunately, I have had to be at the emergency room with one of my boys twice in the last month. So if, hopefully none of the other commissioners have had to go to the hospital, but you probably should walk in there and see how bad it is. It was unbelievable the other day when we had to be there, the amount of people just in the hallways, back in the emergency room, not even out front. So obviously we have a staffing issue at the hospital. We have this issue, and this has been a major issue, I think, probably for all the commissioners have heard about the wall time and that kind of stuff. I guess my question is AMR or any other ambulance service required once they are in the hospital? Is that now legally the hospital's patient, or are they still in charge of this person? And I think that's where some confusion, that's where I would like to kind of answer, because I also understand that if you are an EMT, if you're a paramedic, if you're a firefighter or a police officer, you want to see that person through that situation and you don't want to feel like you're dumping them. But when we're in the situation where we don't have enough ambulances or people to get to people, then that makes it a whole other issue.
It does. And so it does. So some of the challenge parts right now is just that learning of who's responsible. Now, there's certain requirements for the hospital that anybody's within 200 feet of the facility, it's their responsibility. Now, it is their responsibility, but there's also continuity of care. So taking ownership of that patient, getting them registered, start transitioning, giving that provider feedback to make sure that you're giving that quality of care. Now, what I will say is if you have somebody in the field that needs to be transitioned out, absolutely, it's good to give quick turnover. There also needs to be processes for both the EMS provider and the hospital to know this patient's going to immediately go to triage. This patient's going to immediately go to a room. This is going to be a wall. This is going to be a situation that has to be on a wall. In certain areas, they have teams of nurses that actually manage the wall, or they partner with or have to work with the EMS provider to make a cluster of patients being seen by one or two providers so they can resource back into the community. There are a lot of ways people are still trying to tackle that today. So to answer your question, there is that piece about 200 feet. However, there are some challenges as it relates to how that's applied operationally to make sure that continuity of care for patients.
Yeah, and especially if you've got one nurse to 20 patients at this point, it's kind of hard to have nurses out in the hallway with the patients that are on the beds. So.
And they have tough jobs just like the paramedics and EMTs.
Yeah, it's definitely a multifaceted, like you said. Thank you for your information.
Appreciate it.
Commissioner Frazier?
Thank you, Madam Chair, and thank you for a really great report and study. This is long overdue. I appreciate it. And I want to thank all of our emergency response agencies for really working hard through some very difficult and trying and challenging times. I know it's been kind of tough. And please excuse me if some of my questions or just asking for clarification on some of these points is very elementary. There's a lot of moving parts here, a lot of information, and you know, we're not in this day in and day out like you all are. So I kind of just going through the report, starting with, it states that you were evaluating the entire EMS system, but it didn't include all of the emergency response agencies. And it goes into the method was counting the numbers of service requests, including both dispatches and the calls, and then tabulating the total number of resources that responded to these requests. So my question is, so how are the numbers accurate when, for instance, KFD was not included in those calculations? KFD and other agencies, they've been left out of the study, but they are expected to serve. So if you could first touch on that.
Yeah,
clarification
absolutely.
point, please.
So 2 parts of the clarification. Number 1 is the data that was asked of us to use to evaluate your system actually came from American Medical Response. So when we worked through our process, when we talked to the county, the cleanest set of data that you had for us to be able to process was from American Medical Response. So there was no other data for us to be able to go through and work with from a first response perspective. So as we started to walk through that, that was the design component to that. Understanding that you already have the medical first response within the community. The second part to that was to look at the EMS system as it relates to the contract moving forward for the RFP. So the design was for moving forward, and that's why the accrediting model that we used allowed for using that first unit based around the medical first response, and the second unit being around the transport unit, so we could model that for you and within your community because of some of those limitations.
So will the RFP, is it based on including those responses or not? Because I'm just concerned that our RFP isn't going to fully have the scope of service that is actually our model or who we're responding to. I mean, especially in the Mission District. I mean, that's the portion of the city it causes significant demand. It will require a multifaceted and multidisciplinary approach. So the EMS contractor gets that burden. Well, my first thought was, well, why are we not contracting with KFD? Are we fully utilizing the agencies that we have or any other nonprofits that could assist?
We've actually started looking into that one particular area just probably about a month ago because it would take more than a paramedic or an EMT to handle such volume. Your basic EMT cannot tell an individual that has called 911 that they should not go to the hospital. They are designed to transport. So what we've done, our public health officer, Dr. Edwards, brought in the groups that work inside that community, so your VMCs and your CARMs and Salvation Armies, to start looking at alternative service methods that we looked at last year's calls, and it was 2,100 transports. Almost half of those were low acuity, meaning we used a unit to transport an individual probably to UT Medical Center that probably didn't need to go. So how do we put providers down in that area to address that before the call is ever made? We also found that a majority of those calls were made right before the medical staff at CARM actually comes in at 7 a.m. So it's shift change. So can we just bring somebody in a little bit earlier? Can we have, local area hospitals bring in a provider to help us with that? What does that look like? It's to address that problem is much more than local EMS or first responders addressing it. It takes many more people than that.
Yeah. And you talked about requiring a software program that automates the process. And I found it very interesting that it stated that this is currently done manually, which is a little frightening. Does the RFP state that the contractor will own and operate their own operational and clinical performance software at their cost? And if so, does that mean that we, again, don't have or own the data?
We own the software. We will ask the contractor to pay for that software. So
that data will be ours?
It will be, yes.
Okay.
Right now, for instance, if you were to have a constituent reach out with a complaint or an issue or questions, everything is retrospective and also manually calculating time. I get data from AMR, and then I call Director Anders' group up, and I get their data, and I compare them to make sure that they're the same thing. And then you have to manually add things together to get there.
And I know at one time we had talked about the transport of deceased persons, possibly carving that out of the scope of services, but it was still included.
It was, yes.
Okay.
I say we. The county went to bid for that, and Director Myers, I wanted to believe we didn't actually get any responses the first time we bid that out.
And let's see, and I know this is a very elementary question, deployment modeling. I'm just a fact-based. How many ambulances do we need to cover our county? I mean, just as
depends on the hour.
Simple and elementary. I mean, how many resources? I mean, I know it's a moving target.
Sure.
It's a totally moving target, but then my question is, how do we measure efficiency? And then what is the standard wait time for a county this size? What have you seen in other counties?
So I'll just answer that. So depending on the model you chose, and here was the 1020 model, which the county chose, it'd be 17 at peak a day for ALS, and it'd be 4 at 24/7 for BLS. And so that's where our modeling goes. Now, that was what we looked at. And again, by system design, by challenges you might have in the hospitals, you may have to increase that. It's just going to all depend on what your contractor is going to ultimately deploy. Now, that was our modeling for this, which is more than you're currently to perform to 17 minutes today is going to be expected of your contractor.
Okay. And that, my almost last question. Do you think that that can be accomplished with one contractor? I mean, it states in this several times about multi-agency, multifaceted approaches, tiered responses. And then you said that anything in the RFP and the proposals that receive, every point can be taken in consideration. Are we considering more than one?
Contractors have the ability to work together to bid. So if 2 agencies wanted to work together, they could do so. However, there would be one agency that would be the true contracted agency for the county.
Okay. And have we reached out to funeral homes about deceased transport?
That one I don't know. We would, Director Myers, decedent transport, do you know? Yeah, the decedent transport RFP.
Question again, please.
Commissioner Frazier had a question about decedent transports in the RFP.
I was just wondering, have we reached out to our funeral homes about potential contracts with them for deceased transports?
It has been a couple of years when we reached out. Very few were interested. Now, keep in mind, we've had this COVID thing. It's been around since 1920. So we have not reached back out. We did, as Mr. Parton said, issue a solicitation several years ago. Had 2 respondents. We just, at that time, did not have the funds to go in that direction.
I guess I'm asking, do we have some flexibility here to be creative, or are we just? I feel like, and I've spent so many hours just researching and Googling and looking at other areas and how they're responding to these situations, and every time it takes multiple agencies, a coordination of those services, even nonprofit agencies, and I just worry that this pigeonholes us a bit. So I want to make sure that as a county, to provide the most comprehensive emergency response services to every citizen in every corner of this county, we are looking at every available resource. And so that's, just want to say that. And then the medical director, is this part-time? And is it the same, the system medical director, it says we'll have authority over the county, 911 comms, EMS contractor, and first responding agencies. But I think the RFP states it as a part-time. I can tell you from experience, it absolutely is not a part-time job. And at $50,000, you're not going to get anybody to do the job.
So that's all going to be derived from what you want locally. So I will tell you, in other systems similar to the size of this, that is what they see as about a part-time, and that's what we've seen other folks pay for this. So that's not abnormal. Now, it all depends, again, on what you're looking for and what your community wants. If you have one individual that is full-time and the county wants to pursue that and take on that cost, it's a local policy decision. However, it's all about how that level of engagement that you want from the individual. So again, it's how you want to design that. However, the option for making sure that as you walk through the community, our goal for that recommendation for you is to ensure you have that systematic approach to quality of care for the citizens here.
Those are all my questions. Thank you for your patience very much. I appreciate it.
Thank you, Commissioner.
Mm-hmm.
Commissioners, I know we still have two lights on. We're running a little short on time. Are these short questions, Commissioner Schoonmaker?
Thank you, Madam Chair. This summer, the state of Tennessee, their health services and development agency, who are the ones that are responsible for issuing the certificate of needs for hospitals and communities. And they had an application in front of them for a freestanding emergency room facility at the intersection of Middlebrook Pike and Weisgarber Road. For whatever reason, they turned down that application for a freestanding additional emergency room. So if we would have had 6 emergency rooms online than we currently have now of 5, in your professional opinion, would that have reduced wall times?
I don't know what I don't know. And here's why I'll say that. That's not something we do as a firm studying that side for the hospitals, so I wouldn't know. But I couldn't even gather to tell you. I don't know if you have enough nursing resources to handle that in the community. I have no idea. So that's an unknown for me that I really couldn't be able to comment on.
Okay. But obviously if they're going to go to the expense of running a 24-hour emergency room facility, they're going to have it staffed. But I was just surprised that they turned it down in the size of a community that's growing.
Yeah, it's a freestanding ED, maybe. But if it's an urgent care, again, from a 911 response, we don't have the ability really to transport to urgent cares from a 911
No, this is an emergency room only. Fully
Perfect.
staffed, trauma, the whole thing.
Understood.
Okay. Thank you.
Thank you. Commissioner Daly?
Thank you, Madam Chair. Director Parton, Director Myers, next month when this comes to us, are we going to vote on your recommendation for one provider? Will we have a choice of 2 providers, or how is this going to be presented to us in November? Because right now I don't know what we're going to be looking at, how to vote or whatever. So if you could explain the process of how many, 1, 2.
My understanding of the process is the evaluation committee will make a recommendation to me. That will obviously be discussed with the mayor, and the recommendation that comes before this body will be for one of those models. We don't pick and choose, so you will get a recommendation on one of the models, the one that we feel is the best fit for Knox County.
Well, that's the way I thought it would happen, because we're sitting up here asking questions that we're not on the committee, so we don't know what's happening in the committee. So it will be one, it will come out of the committee as who they recommend.
Correct.
We can pick or choose.
Yes, you can vote it up, vote down.
Thank you.
Yes, sir.
Thank you. Thank you so much. This has been wonderful, wonderful information. I'm sure there's probably still many more questions, and we'll discuss how best to handle that. Thank you, Mr. Sheridan, for coming and giving us your time and such a thorough rundown, and Director Parton, Mr. Myers, everyone. We appreciate it very much. And on that, we will adjourn and start Beer Board at 4:05.
Thank you, Commissioners.